PET-CT unit.
Okay. Hi everyone, it's me, toqa, radiology resident at Ain Shams University Hospitals. I'm here today to represent you another interesting case that we encountered at Nuclear Imaging Unit in the last few months. First of all, I'd like to acknowledge my special gratitude to my lovely, all-time supportive supervisors, Dr. Minatullah Hatem, Dr. Hiba Naggar, and Dr. Amra Hanafi. Thank you all for honoring me the chance of being here among you today. I'll discuss my case with you on the following, or on the shown 5 axes. Starting with the clinical history, she was a 30-year-old female patient with a recently diagnosed right breast cancer, admitted to hospital complaining of progressive muscle weakness and skin manifestations. Here's the sonomammography report revealing a small retroareolar mass lesion with ipsilateral pathologically looking axillary lymph nodes in keeping with PARADS 4B that turned out to be invasive ductal carcinoma grade 2 on histopathological assessment. Patient was candidate for PET-CT imaging as a part of her metastatic workup routine. Having a look on the Q-clear imaging, it looks confusing somehow. The tracer is dispersed everywhere, right? I can see it popping to your minds that this patient must have not been, she wasn't well prepared. We also thought so. We thought that patient might have intense physical activity prior to study date, or she might be diabetic patient and received a high insulin dose at just before the study. So we contacted her physician. Surprisingly, we found out that patient was medically free and bedridden for days before the study date. So we analyzed the case as it is. Starting with the primary tumor site, you can see bulky right breast region with no metabolically active lesions. Having a look on the ipsilateral lymph nodes, it shows rounded, suspicious-looking lymph nodes, however, with no active uptake. In reviewing chest cuts, the patient had bilateral inactive pleural effusion with related consolidation collapse. PET-CT imaging have no active foci as well. Back to musculoskeletal assessment. It showed increased metabolic activity involving proximal muscles of shoulder girdle and proximal thigh muscles. Also, increased metabolic activity of the upper back muscles and anterior abdominal wall muscles. However, with SUV max reaching 4.89. However, lower back muscles and gluteal region was spared somehow. So we have a uniform symmetrical muscle uptake affecting shoulders, upper back, anterior abdominal wall, proximal thigh, sparing lower back and gluteal region. Okay, let's remember rule of PET-CT. As we all know, PET-CT mainly used for as a standard tool for detecting malignancy, staging for tumors. But what I'm here for today is to remind you how it works. Actually, we mustn't lose sight that PET-CT detects increased metabolic activity, not only in the rapidly dividing malignant cells, but also in the inflammatory cells. So PET-CT can also be useful in diagnosis of systemic inflammatory diseases. I'll pause with you for a minute to sum up what I mentioned. By history, we have a 30-year-old female patient with right invasive ductal carcinoma, and her main complaint now is progressive muscle weakness with skin manifestations. And on imaging, aforementioned details regarding primary site at distant spread, revealing that she has no distant myths, but increased metabolic activity or skeletal system with a specific distribution. So I'm here having two questions for you. First, I mentioned that patient has a pathologically proven malignancy. Why didn't it show up on PET-CT? I told you there were no active lesions in the breast, actually no active uptake in axillary lymph nodes. Can anyone tell? Sorry? Sama. Muscle atrophy? لا. Breast lesion. I'm mainly talking about the breast lesion. I have a pathologically proven malignancy in the breast. Okay. The lesion might be, sorry? It might be mucinous cyst adenoma, but pathology told that it's invasive ductal carcinoma. Mucinous tumors, like mucinous cyst adenocarcinoma, aren't detected by PET-CT or by FDG tracer. Second thing is that it might be too small to be detected by PET ultrasound. But what what I'd like you to see, or that most of tracer dose was consumed in the muscles. Okay. Second question is, what's our provisional diagnosis as regard the muscle affection? What's the provisional diagnosis? Okay. Patient have a systemic inflammatory disease affecting muscle and the skin. Turned out to be dermatomyositis. Now, having an overview on dermatomyositis, it's one of idiopathic inflammatory myopathies, the etiology being autoimmune-mediated cytotoxicity. However, it might be associated with viral infections like Kawasaki virus, enteroviruses, or might be associated with malignancies as a part of paramalignant syndrome. It affects females more than males with peak age of 30 to 60 years. Characteristic diagnostic criteria of dermatomyositis includes clinical criteria of symmetrical proximal muscle weakness, characteristic skin manifestations in forms of cutaneous papules affecting her hands, or child signs, skin manifestations affecting neck, or malar lash affecting checks with nasolabial folds affection, unlike systemic lupus. Also, dermatomyositis in advanced cases may affect lung in forms of interstitial lung disease, or might cause congestive heart failure or GI vasculopathies. Here is the diagnostic criteria of dermatomyositis: symmetrical proximal muscle weakness, characteristic skin rash, elevated serum muscle enzymes, myopathic changes on electromyograph, and the standard tool is muscle biopsy. Back to literature. In 2020, Hanai et al. Conducted a study to evaluate role of 18-fluorine FDG muscle uptake in patients with dermatomyositis and polymyositis, and correlated the results with serum muscle enzymes. Increased metabolic activity was observed in nearly 80% of patients with dermatomyositis and polymyositis, and 7% of patients with controlled groups. However, number of positive regions, total score, mean SUV max, mean SUV mean were significantly higher in the diseased groups than control groups. Also, as I mentioned in the case, in that study, muscle uptake was have symmetrical distribution, affecting shoulders, buttocks, upper thigh as the most affected sites. Correlating the results of those parameters with serum kinase and aldolase levels revealed high association. Here's image on the left of the control group with no muscle activity and the diseased group showing increased activity. PET-CT also can give useful in determining the activity of interstitial lung disease in those patients, which is a critical complication. It can detect interstitial lung diseases even before it's clinically manifested. Also, it showed that that parameters, the CUV max and others, are nearly normalized after patients receiving treatment. Thank you all for your attention.
شكرا توقا. هاتي بس الصوره بتاعت البيب تاني كده. انا بس عايزه اعقب يعني حاجه على الحاله دي بالذات، لانها برضو من الحالات